Obesity is a national epidemic. There is a clear association between social-cultural factors and health outcomes. The ACOSS Poverty Report 2011 demonstrates the lower socioeconomic status combined with employment, education levels corresponding with poorer health outcomes. Social-cultural factors are characteristics such as customs, lifestyles, and values that define a group. Cultural aspects might include concepts of education, language, migration, family, and status in society. An understanding of sociocultural factors is crucial in developing obesity-related health programs aimed at targeting groups at risk in southwestern Sydney local health district area. This presentation identifies the impact of sociocultural factors affecting the health of residents in southwestern Sydney, factors influencing obesity, inequalities, and improving the health of southwestern Sydney residents.
According to Gurmov, 2009, the social model of health suggests society is a reflection of behaviours and vice versa. Social-cultural and socio-economic factors are intertwined and equally impact health and social determinants as well as inequalities. In her report for Australian National Preventative Task Force 2009, Dr. Sharon Friel confirms choosing to eat healthy food, being physically active, requires people to empower to make these choices. It means that the healthy choice must be physically, financially, and socially the easier and more desirable choice relative to the less healthy option. This is not always the case, particularly with decreasing social position. In 2009, Friel stated what and how much people eat and how they expend energy are responses to their socio-economic and socio-cultural environments. The World Health Organization defines obesity as the abnormal or excessive fat accumulated causing risk to an individual's health. As mentioned before, it is a rising epidemic in Australia and it's something that needs to be addressed as soon as possible. Let us view a snapshot of obesity across Australia from the New South Wales Department of Health. It can be seen from these statistics that the link with rural and disadvantaged areas correspond with higher levels of obesity. In 1995, the Australian National Health and Nutrition Surveys evaluated the relationship between social factors and body mass index across socio-demographic groups. Social factors remain significant predictors of BMI. The study also concluded that there are additional factors that contribute to health behaviours and would also contribute to the difference in obesity prevalence across socio-demographic groups. Socioeconomic factors have been considered in this presentation. Southwestern Sydney, a highly cultural diverse local socioeconomic area. Population comprises of mostly non-English speaking background and has a percentage of 22.8 obesity rate, much higher than that of North Sydney, which is only of 8.5%. Achieving equality does not rest on the number of health services provided, rather the access to services, awareness of programs available and education of good practices. Here is a little map showing the areas where health services are provided, as well as the southwestern Sydney location itself.
As per the Southwestern Sydney Local Health District Profile Report, predicted growth suggests that Indigenous, migrants and refugees, as well as people with disabilities, are groups at risk in this region. These groups form the major contingency of this region. Between 2005 and 2011, 10,932 refugees settled in southwestern Sydney. Intake of refugees are from countries including Afghanistan, Iraq, Sudan, and the Middle East in general.
Food subsidy policy has adversely affected the food habits in some regions in the Middle East by encouraging the intake of fat, sugar, rice, wheat, flour and meat. Moreover, gender discrimination, education and lack of physical activity form the gender characteristics of these risk groups. Language barriers contribute to the lack of education, thus income and lack of awareness of health services. In cases where people become socially withdrawn to pressure of restarting a new life in a foreign country, thus increased stress levels, people not only lose a connection with society, but also engagement and participation in health support programs. The ACOSS poverty reports outlines people with less money, less education, insecure working conditions, poor living conditions, and often excluded from mainstream society are much more likely to die early and have higher levels of behaviour-related health conditions such as obesity. As per the New South Wales Agency for Clinical Innovation for the Indigenous groups, we must ensure knowledge sharing, partnering with healthcare providers to support collaboration, learning capability and knowledge sharing on healthcare innovation and improvement. The benefits of knowledge sharing help to develop a culture of learning and contribute to providing more accurate and accessible information. Furthermore, Dr. Jennifer O'Dea suggests obesity prevention is essential. Anti-teasing and bullying policies are very powerful ways of changing the whole school environment to promote a greater diversity in body shapes and a greater tolerance of individual differences. These improvements are also likely to increase participation in physical activity. Despite some progress in making facilities physically accessible in New South Wales, accessibility has yet to be improved. For refugees and migrants, we must assure a comprehensive, efficient and transparent process for assessing health technologies. The region requires programs with explicit objectives and outcomes similar to those run by the New South Wales Agency for Clinical Innovation, specifically for Indigenous groups around Australia. New South Wales State Knockout and the One Deadly Step program are examples of programs linked to groups at risk. These programs specifically target Indigenous groups and have become successful in engaging communities.
The ACOSS Poverty Report 2011 confirms that we should commit to an obesity prevention plan, starting with defining obesity as a disease and gaining additional federal support for prevention and interventions.
Continuing on, supportive and engagement support programs, policies and regulations in non-health sectors are needed in order to address the underlying social causes of unhealthy behaviours. Some points that need to be addressed are improving patient experience, access to care, information and education on obesity and health, physical comfort and activity, emotional support and alleviation of fear and anxiety, and the implementation of friends and family being a part of day-to-day activities and health initiatives. Social-cultural factors must be understood as they vary from suburb to suburb and should be addressed as critical factors contributing to obesity.